So as we are hearing here, and number one is nowadays in regard to local therapies, there's different options. We heard from Riyadh that chemoembolization and blood embolization almost are equal based on some data that was reported from Sloan Kettering by the group there with Karen Brown. On the other hand, the favored approach because of the level 1 evidence and really the most commonly used in the world is chemoembolization per se. We heard quite a bit about the radioembolization approach, and maybe something we didn't touch on, but at least there is a certain understanding that probably patients with a vascular involvement might be more prone for the radioembolization as well. Then we touched on a little bit more debatable subject. One effort that has been brought up in regard to the use of systemic therapy being sorafenib at that time with the chemoembolization. The first efforts were actually not in favor, and there was a debate about like maybe they waited too long until they started the sorafenib after the embolization. This was circumvented by other trials, among which the TASTE-2, as we heard, and others, and we really, or the space study, and we really still did not see the benefit per se. And then, as Peter said, the advent of the approach of the checkpoint inhibitors with the embolization is relatively new. There are some first reported data that appears to be exciting and inviting in regard to the potential, but of course we need to further analyze it per se. And the question is it really a matter of, because if we go back to the sorafenib, the story was maybe the embolization might cause a certain angiogenic drive, exactly as Judah Folkman has told us for years in regard to what we do to the tumor and how we excite the tumors per se. And that was the idea of the anti-angiogenic like sorafenib might really address that. On the other hand, the alteration in regard to the immune system that the embolization will do, let alone that the tumor by itself is in the immunogenic environment, as such the checkpoint inhibitors might do the job. The question is, however, that I'll bring again back to Amit is, do you think it's going to be really checkpoint inhibitors, or do you think we're going to go back to one more time to the drawing table and maybe we're going to bring back the TKIs and maybe we're going to have everything all together, like embolization plus checkpoint inhibitors plus TKI?
Yeah, I mean, I think it's an interesting question. I think this goes back to Peter's point that you have to weigh any kind of efficacy against the toxicity. So the more and more drugs you add, the more and more toxic your combinations are going to be. So at least personally, I hope that we don't end up combining all three. I think that really at that point, I think that I'm hoping that we do this in some kind of actual thoughtful fashion here. So I think right now, with the excitement about the checkpoint inhibitors, as Peter went through in terms of the mechanism of why this may work, I think that would be the next best study, is to combine the checkpoint plus TACE. And then we can see how the other combinations tend to work together, and then we can go from there. But I think that throwing the kitchen sink at an intermediate stage tumor, you're going to invite a lot of toxicity for probably little benefit.